All right, we just did the cholinergic neurotransmission, and we're sort of on the home stretch, at least of autonomics, with adrenergic or noradrenergic neurotransmission. So as we talked about before, one of the one of the ways of differentiating between the parasympathetic system and whether it's sympathetic or parasympathetic in the autonomic system is the neurotransmitter that's used. So in adrenergic or sympathetic system, we are mostly using norepinephrine at the level of the nerve terminal. So I just have two of the different pictures here. I believe one is from clinical pharmacology and the other one is from first aid, just showing, because you guys have so many different drugs that you have to know specifically in this section, that it sort of highlights both of them. I guess we'll start over here. One of the things I wanted to point out, so we have the alpha and beta receptors on the postsynaptic nerve. Just really need to remember that the alpha 2, though, is actually a presynaptic receptor, and that becomes extremely important later on. We have some agents that act as reuptake inhibitors. You'll hear that term quite a bit. Those include cocaine, tricyclic antidepressants, and amphetamines. There are also agents that can increase the actual release of the norepinephrine, like amphetamine and ephedrine. We have reserpine, which was actually one of the original antihypertensives, one of the first agents that was discovered in that could modulate neurotransmission, which actually inhibits this VMAT transporter over here, which brings norepinephrine into the vesicle for storage. Tyrosine, obviously, if it's a metabolite, its increase can cause changes in the amount of norepinephrine made. Then we have some other sort of lower yield agents. Met-tyrosine, which I guess is it's an inhibitor of the cascade of creating tyrosine into dopamine. We also have beryllium and guanethidine, things I've never heard of. It looks in this case that they're inhibiting the vesicle from releasing the norepinephrine into the nerve terminal. Again, sort of lower yield, and I'll let that be known again when we go over it on their individual sections. So, as I said before, the side effects of the cholinergic and anticholinergic neurotransmission being like the most important part of that section. This is the most important part of the adrenergic section. You have to understand that in this case, they were able to differentiate between different receptors. These receptors are located in different areas, and they have different effects because they are located in different areas. So, alpha 1. An alpha 1 receptor, alpha 1 receptor, it's postsynaptic and it's GQ. I wouldn't really worry so much about GQ, GI for this exam, but it is something that is testable and fair game on the boards. It's postsynaptic, so if we stimulate alpha 1, we have an increase in vascular smooth muscle contractions, so we actually contract our blood vessels. We have mydriasis, pupil dilation, and then we also have an increase in the contraction of our bladder and our intestinal muscles, so we're actually slowing down our gastrointestinal tract because we're contracting our sphincters. So alpha 1, 100% think smooth muscle, think vasoconstriction is alpha 1. Alpha 2 is the odd man out or woman. It is presynaptic, so actually when you release norepinephrine, it's going back, or whatever agent you're using, it's actually activating the actual nerve that the neurotransmitter is being released from. So in this sense, we're actually it's sort of I like to think of it as a it's like it's an auto-regulator. If you have too much of that neurotransmitter in the synaptic cleft, it's going to start spilling out into the sides, and it's going to start activating the alpha 2 receptor, and it's the way of the nerve of regulating how much neurotransmitter it's actually releasing. So when you activate alpha 2, you actually reduce sympathetic outflow. So you're decreasing the actual norepinephrine getting released further by the nerve terminal. So that's a very, very important point. So, you can be used to treat blood pressure, alpha 2 agonists, because if you give something that stimulates alpha 2, you'll have a decrease in sympathetic outflow. It also can decrease insulin release and decrease lipolysis and decrease aqueous humor production. Those things aren't as important as understanding that alpha 2 is reducing sympathetic outflow. And when I talk about the agents that work on the alpha 2 specifically, I'll explain more some of the things that it can do because of that effect of regulating the release of neurotransmitter. Beta 1 and beta 2 receptors. Extremely important to know location. What I was taught was beta 1, you have one heart, so the beta 1 receptors are located on the heart. Beta 2 are located in the lungs, you have two lungs, beta 2. There are also beta 2 receptors in the vascular smooth muscle cells as well, so you can have some vasodilation. But so for beta 1, think heart, increasing heart rate, increasing heart contractility, increases renin release. It's important to know that because when we talk about the beta blockers, this is primarily, even though a beta blocker would, well, I'll get into that, but it's important to remember renin release. It can increase renin release, and it can also increase lipolysis. Beta 2, again, as I said before, beta 2 is in the lungs, so the main effect that you're going to be seeing beta 2 with is bronchodilation. So activating beta 2 can cause bronchodilation, and it can also cause vasodilation. Those are the two primary ones that you want to know, two primary effects that you want to know about for beta 2 receptors. I've included a little bit more information that was in your first aid textbook. There are a couple mentions of aqueous humor production, whether it be increasing or decreasing, or ciliary muscle. That's going to be a little bit more important for boards. That's in reference to these agents as they're used to treat glaucoma. There are many glaucoma agents, anti-glaucoma agents that are used, and whether they're alpha, beta, and what have you. Not so much something you have to worry about for this exam, but for the boards, they could ask you, you use beta blockers for people who are on glaucoma because beta blockers, can relax the ciliary muscle and can decrease aqueous humor production. So not so much right now, but this slide, some of the things I talked about, extremely, extremely important to remember, because if you know the receptor, what it does, if you have an agonist or an antagonist, you know what we're treating and what the side effects may be. Okay, so just to talk about a little bit about the neurotransmitters that are released in adrenergic nerves. So we have epinephrine. Epinephrine, very important, activates beta 1 and beta 2, alpha 1 and alpha 2. Norepinephrine, the precursor, only affects alpha 1, alpha 2, and beta 1. It does not have any beta 2 effect. Extremely important differentiation point. In addition, epinephrine at low doses causes vasodilation because of its beta effects, and at higher doses causes vasoconstriction, or is a vasopressor because of its alpha effects. Very important to remember that. Norepinephrine, as I said, no beta 2, so this is primarily a vasopressor. So some of the uses of norepinephrine and epinephrine: anaphylaxis. We all know that epinephrine is used for anaphylaxis. Asthma. People who are going into acute asthma exacerbations will get an epinephrine injection intramuscularly for the for the beta 2 effects. Not so much vasodilation, but the beta 2 effects on the lungs. Open-angle glaucoma, as I was saying before, these epinephrine and norepinephrine can be used for people with glaucoma. Not as much high yield, but they can be. Finally, shock. They're going to be seen a lot on the floors in your clerkship as pressors, as agents to keep patients' blood pressures up. This is really the only use of norepinephrine. You're really only going to see norepinephrine used in somebody in shock. None of these other three things don't so much apply to norepinephrine. Norepinephrine is primarily used for shock, whereas epinephrine can be used for shock in addition to other things. Dopamine, another important pressor, because there's a high yield dosing that they like you to know. And this might be one of the only times you're going to have to know a drug's dose in medical school. So dopamine, as I was talking about before, if you go way back to the beginning of the lecture, looking at some of the different nerves, there are some nerves in your sympathetic nervous system that release dopamine, and there are dopaminergic receptors. D1 and D2 receptors are activated equally by dopamine. I wouldn't worry about D1 versus D2 quite yet. And I don't think specifically in this topic you would be talking about it. I think that gets a little bit more important in Parkinson's and the pathway and the brain, but systemically, no. It's very important that you remember it's dopamine receptors, low dose. Medium dose, it's beta receptors, and at high dose it's alpha receptors. And it's extremely important to remember. There were test questions on UWorld. This is something that they like to test. So the big thing about dopamine is at low dose you're only activating dopamine receptors. The dopamine receptor acts as a vasopressor throughout the body except in the renal arteries. So you'll actually have a little bit of increase. It actually acts as a vasodilator in the renal artery. So when you give someone dopamine, you're giving them a vasopressor, but you're sparing renal function. You're keeping the renal function open. And that's the big thing that they love to test. It's if you give low dose dopamine in a patient who's anuric or having renal function issues, you're sparing their kidneys. Now, in theory, you're going to get a test. This is what the textbook says. This does not happen in real life. There's a lot of variation in patients who have low dose and medium dose and high dose. There are numbers that are in textbooks, but they don't really correlate to real life practice. But on your exam, when you take the step in June, July, or May, you have to know this. So low dose vasopressor without reducing renal function because it spares the renal artery. At the medium dose, you have the beta receptor effects, and as we talked about, the beta receptors have receptors in some of the vascular smooth muscle, and it causes vasodilation. And at the very highest dose, dopamine is a true pressor. The alpha receptor effects take over, and you have only vasoconstriction, and you have a true vasopressor. So in this case, dopamine can be used in unstable bradycardia. It can be used in heart failure, and it makes sense because in heart failure we still want the patient's kidneys to work, and we're trying to preserve renal function, but we need we need a little bit of pressor activity to keep the heart going and keep the fluid from pooling in our extremities. And then finally, of course, shock. All right, so now we're going to get into the individual drugs that affect the individual receptors. And we'll start off with the alpha receptor agonists, phenylephrine, and then the alpha-2 selective agonists, clonidine and alpha-methyl-dopa. So I'm sure you might have heard about 2 or 3 of these agents. So phenylephrine, it's an alpha-1 agonist. As I said before, the alpha-1 agonists cause blood vessel constriction, which is the most important thing to know. They can also cause mydriasis. I wouldn't worry too much about the mydriasis. I'd focus on the blood vessel constriction. It can be used for upper respiratory infections. I'm sure many of you have gotten Sudafed or phenylephrine when you felt like you had a little bit of a head cold and you had some you had some rhinorrhea. That's what phenylephrine is primarily used for. Upper respiratory infections and allergic rhinitis, because it's constricting the blood vessels in your nose, so you're not able to, leak as much, not have as much a fluid exchange in your capillaries, and you won't have any rhinorrhea. It can also be used for shock and hypotension because it's an alpha-1 and it's technically a pressor. So they do tend to give this in sometimes in patients who have tachycardia and who are in shock. Alpha-2 selective. So as I said before, this decreases the adrenergic outflow. This decreases the amount of norepinephrine and epinephrine that is released in the nerve terminal. So because of that, it can be used to treat hypertension. It can be used to treat hypertension in pregnancy, specifically alpha-methyl-DOPA. If you ever have a female who's got preeclampsia or is just suffering from hypertension and they're pregnant, the number one answer is just go to methyl-DOPA. That's the answer for hypertension in pregnancy. But in addition, clonidine is also used for ADHD and opioid withdrawal, because in ADHD it's thought that you're a little stimulated. You're just a little too much neurotransmission, and so by giving clonidine you can reduce some of that. And then additionally, opioid withdrawal, it's again thought that there's a little bit of a hyperstimulation, so by giving clonidine you're actually able to reduce some of the tachycardia and some of the withdrawal symptoms. Now, if we are reducing the adrenergic outflow with clonidine, you can expect to get CNS depression, bradycardia, hypotension. One of the highly testable side effects is rebound hypertension. So somebody with clonidine, if they abruptly stop it without slowly titrating their dose, they will have rebound hypertension. So that's a very high yield point. And then with methyl-DOPA, they like to talk about there's a lupus-like reaction that can occur, and it also can cause a direct Coombs test to be positive. And then with phenylephrine, a high-yield physiological point, if you're just isolating and agonizing the alpha-1 receptors, you are going to have constriction of your arteries. If you constrict your arteries, obviously your blood pressure is going to skyrocket. It's the body's natural reaction to actually reduce its heart rate when your blood pressure goes up in an isolated fashion such as this. So it can cause some rebound bradycardia. Alpha receptor antagonists. So we're going to start with the non-selective ones, which are you're not really going to see as much, and there's a little high yield point here and there. And then there's the alpha-1 specific antagonists, which you will see all the time. So the non-selective, non-competitive, phenoxybenzamine, and then the non-selective competitive, phentolamine and tolazine. So these inhibit alpha-1 and alpha-2 non-selectively. They just they antagonize with mass effect. So the thing you want to remember is phenoxybenzamine is used for patients who are about to have excision of a pheochromocytoma, and it prevents hypertensive crisis. Phentolamine is used for patients who are having a hypertensive crisis that have ingested something with tyramine in it, which is found in beer and aged cheese and wine, and they are concomitantly on a MAOI inhibitor, which is monoamine oxidase. So monoamine oxidase is involved in the degradation of tyramine, so we have a buildup of tyramine, which leads to an increase in norepinephrine and an increase in some of those neurotransmitters. So this is a very common drug interaction, and phentolamine is the agent of choice used to treat it. In addition, this may be more for your clinical side. If you're ever on the wards and you have a patient who is on a norepinephrine drip and they extravasate, and you have an IV line in and the vein blows and they're leaking norepinephrine into their extremity, there's a possibility of massive vasoconstriction because of the norepinephrine. So phentolamine is an agent to give to inhibit that from happening. Side effects: orthostatic hypotension. So this goes back to what we talked about previously with the rebound bradycardia. If you are inhibiting your alpha 1 and alpha 2 receptors, specifically alpha 1, if you're inhibiting your alpha 1, there's no way for the body, when all of a sudden it stands up and has a fluid shift, to constrict the blood vessels to help it compensate and shunt that blood back to your heart. So when you stand up after sitting for a while, your blood will pool in your legs, and the body doesn't have that natural response. Normally you stand up, your body will vasoconstrict, and then your heart rate will go up to try to increase the blood flow to make sure it gets to your brain. It can't do that if you're on an alpha receptor antagonist. So you get orthostatic hypotension, and you'll also get reflex tachycardia because now the body has to compensate more through the heart because the blood vessels aren't able to accommodate. So very, very high yield for alpha receptor antagonists. Alpha 1s, much, much, much more important than the non-selective. So you have doxazosin, alphazocin, prazosin, and tamsulosin, anything with an osin. So these specifically inhibit the alpha 1 receptors. They're classically used for benign prostatic hyperplasia. They were historically used to treat hypertension, but I don't know if you've had that little Pharm Review small group thing, but if you Google the ALL-HAT trial, which is the trial that looked at which drug is best used to treat somebody with hypertension, it was actually found that alpha 1 antagonists were worse and actually caused more harm to patients compared to some other agents. So we don't necessarily use them for hypertension anymore. However, if we have a patient who has BPH and they have hypertension, and it's sort of like killing two birds with one stone, then we can use it to cover both things. As I said before, it can cause orthostatic hypotension because you don't have that body's ability to vasoconstrict and compensate for fluid shifts, and it can also cause reflex tachycardia. All right, beta time. So very, very, very important drugs right here. I guarantee you will see these all the time. Isoproterenol is our non-selective beta receptor agonist. We have dobutamine, which is our beta 1 receptor agonist. We have some short-acting beta-2 selective agonists, albuterol and metoprolol, and then we have long-acting beta-2 agonists. So obviously the mechanism is we're activating our beta receptors. Side effects of all of these medications are tachycardia, tremors, and arrhythmias. So I broke it down onto uses on the other side of the slide. So albuterol and metoprolol. To be honest, I've never even heard of metoprolol, but albuterol I'm sure many of you have already heard of. These are used for short-term control of asthma as well as COPD. So our beta agonist, beta 2 agonist that is, cause bronchodilation. So obviously we know asthma is a reactive airway disease, can cause some vasospasms and some bronchospasms and constriction. Therefore, we give a beta 2 agonist to open up our airways. It can also be used in acute asthma exacerbations and COPD. So albuterol is our rescue inhaler, and it is also our a nebulizing treatment that we can give to patients who are in immediate need of airway help. Now, salmeterol and formoterol are both our long-acting beta-2 selective agents. So these are for long-term control of asthma and COPD, mainly asthma. We do not use these as rescue inhalers. We thought that it would be a good idea. We can give a long-acting beta-2, and it would help cover patients and they wouldn't need to use their short-acting. It is not approved for that, and it has actually been found to have an increased risk of death when used alone. So now you'll see it with Advair, which I believe is, sorry, I'm drawing a blank and it's very embarrassing when I don't know a brand name and its generic name, but beyond the point, it's they're all given with steroids. So you'll always see a salmeterol or formoterol given with fluticasone or some sort of inhaled steroid because they were found to have an increased risk of death on their own. Another very high yield point. They will test that. Isoproterenol. Isoproterenol is another pressor, so it non-selectively can agonize beta 1 and beta 2. So it is used in shock, and it can also be used in acute asthma exacerbations because it's an IV form, and it's a way that we can give an IV beta 2 agent to reduce bronchoconstriction. Again, we can use the beta 1 effect to increase heart contractility and helping if it need be for blood pressure support. Dobutamine, again, another pressor. Beta 1 support, we're able to increase heart contractility and rate. Not so much. It has I believe the term is tachyphylaxis. We might have talked about it in one of our first lectures. So dobutamine exhibits a rapid tolerance, so it can only be used for a few days before a patient becomes tolerant to its effect. It is primarily used nowadays for cardiac stress testing. Beta receptor antagonists. So we have our non-selective beta antagonists, propranolol, nadolol, pindolol, temolol. We have our non-selective beta antagonists with alpha-1 activity, alpha-1 antagonism activity, labetalol, carvedilol, and then we have our beta-1 cardioselective, which really isn't so much true, but we still say so. You have acebutolol. Now I wrote ISA. I should have spelt it out, I apologize, but ISA stands for intrinsic sympathetic activity. So therefore, we're blocking beta 1 with acebutolol, but it has a little bit of beta 1 antagonist effect. So it's sort of like a partial agonist. So for example, you had a patient who had maybe some sort of arrhythmia or that you wanted to control, but they were on the side of being a little too slow. So it was, I guess in theory what they like to say is if you're bradycardic, but you have some sort of arrhythmia that, maybe you have a first degree heart block, or the theory is you come in and you have a bradyarrhythmia, but you have some other sort of sinus, some sort of rhythm disorder. You can give a beta blocker with intrinsic sympathetic effect to give them some beta 1 so that they don't go slow, but then you can also block beta 1 so that they don't go too fast. It's entire theory. I've never seen that drug used. I doubt you'd ever see anything like that actually when you're on your clinical rotations, but it's something they like to talk about and you have to know. Atenolol. Atenolol has more beta 1 than beta 2 activity, but it still has beta 2 activity. Metoprolol, which is our pure beta 1 cardioselective beta blocker, which is the most popularly used drug. We have esmolol and nebivolol. So these all inhibit the beta 1 receptors, except for the ones that I mentioned over here on the other side with other activity. They can be used for arrhythmias, AFib, tachyarrhythmias, yada, yada, yada. In heart failure, they've found to have a mortality benefit. They can be used for angina, for reducing the amount of, decreasing the workload of the heart by actually blunting the fact that it can't beat faster. They're used for hypertension historically. They're still used today for hypertension, but they're not very good. We have other agents that we used before we used beta blockers and many more things. Adverse effects. The two things that are extremely high yield that I try to drive home, I did this last year, it's very important to remember, is that they can cause bronchospasms and they can cause hypoglycemia. So, now, it depends on which agent we're using. By blocking beta 1, you mask the symptoms of hypoglycemia. So if you've ever talked to a diabetic, one of the things that they'll tell you is that the first sign that they realize that they're getting a little hypoglycemic is they get tachycardic and they can feel their heart rate go up. If we give a beta blocker with beta 1 blocking activity, they don't get that tachycardia, and so they don't feel like that they don't feel as though their sugar's going low. Point number one. Point number two, blocking beta 2. Now, it doesn't necessarily cause bronchial constriction, but it could, it could make an asthma patient more susceptible to having bronchial constriction. So we know right now, I'm in the Mount Sinai emergency room. Every single patient, or a lot of them, are coming in and they're saying, the weather's changing and I'm just having the shortness of breath. And, they're having a little bit of a reaction to the airway, to the change in the weather and temperature. It's getting a little bit colder outside, and they're currently asthmatics, and they're not dealing too well with the change in weather. My thought is that by blocking the beta receptor, the patients may be even more susceptible to these changes in weather, or just triggers like a common cold that could cause them to have an acute asthma exacerbation. So it's very important to remember you don't really want to give an asthmatic a beta blocker. And specifically, you don't really want to give them a beta blocker with beta 2 activity. So, in addition, the beta 2 receptors, as we talked about way back in the beginning, beta 2 receptors actually increase lipolysis and gluconeogenesis. So, beta 2 can actually stimulate glucose creation. So, if you have a patient who is getting a little low and a little hypoglycemic or diabetic, we actually are blunting their ability to generate glucose. So that's why you really don't want to give beta blockers to diabetics, because you can actually blunt their symptoms of having hypoglycemia, which is blunting their tachycardic response, and you can actually blunt their ability to make glucose and sort of physiologically rescue themselves from being hypoglycemic. So very, very important bronchospasms from the beta 2 receptor antagonism, and hypoglycemia masking the effect from beta 1 and masking the physiologic rescue from beta 2. So you got to be careful with diabetics and asthmatics giving beta blockers. So, for example, metoprolol may be a little bit safer to give a diabetic and an asthmatic than atenolol. It's definitely going to be, both of those are going to be much safer than propranolol, nadolol, and pindolol, because those block beta 1 and beta 2. So, very, very high yield side effect and physiologic mechanism that they like to test. And then finally, beta blockers are another one of those drugs that you need to slowly withdraw, because if you suddenly discontinue the drug, you can have rebound hypertension. So in the beginning, when I was going over the nerve chart, the nerve terminal, there were a few other agents that were mentioned, and they're on your drug list. I don't think they're as high yield as some of the other ones, more so like you want to have some name recognition and a few of the facts that they're known for. So, amphetamines, nobody knows what these drugs are used for. So, these work in the nerve terminal. They act as a general agonist, they act as reuptake inhibitors, and they can actually increase the release of stored catecholamines. They can be used for narcolepsy, obesity, and ADHD. And they've been found to cause hypertension. Obviously, if we're increasing the amount of stored catecholamines, we're going to have more adrenergic tone, leading to hypertension. They can lead to anorexia, and they can lead to euphoria and some addictive effects. So I counsel everybody who's, taking any amphetamine-like substance, the counseling point would be if you're going to be using, you want to make sure you eat a nice big meal before, because when you start taking these drugs, or when you take your dose of the drug, you're going to have it's going to have this anorexic effect where you're just not going to be hungry for quite a long time. So it's good to make sure you eat before you use the medication. Tyramine, I believe I took this from the notes in the professor's thing in and of itself. These are taken. This is an endogenous. This is a substance that's found in food that's taken up by your neurons, and it eventually gets converted into norepinephrine. As we talked about before, if you have more of it, you can potentiate the adrenergic effects of norepinephrine and epinephrine, and this is seen when the patient's taking an MAOI, a monoamine oxidase inhibitor, which is a drug interaction. I talked about it before. That's really all I would know about tyramine. Ephedrine. Ephedrine is interesting. It's very similar effects to phenylephrine, the alpha-1 agonist, only it works by increasing the amount of stored catecholamines, and it increases their activity. So it can be used as a nasal decongestant. It can be used for urinary incontinence. It can also be used for hypotension. Reserpine, I talked about this one before. It was historically an antihypertensive, and it blocks that VMAT transporter, which moves the norepinephrine that's made in the nerve terminal, in the presynaptic nerve into the vesicles for storage. And finally, we have two more, guanethidine and bertilium. These just block catecholamine neurotransmission. I wouldn't worry too much about the drugs on this slide. I have them here for completeness sake. Maybe know the bolded sections and know a few facts, but I would say name recognition and know that they're not direct agonists of any of the receptors. They just, in different ways, potentiate norepinephrine and its release in the nerve terminal for whatever reason I just mentioned. And so we have a few pictures here. I believe there are some charts that you do have to know. So I thought I'd provide you with a few and we could just go through them because it's one of the things you may be asked on the exam. So we have norepinephrine, epinephrine, and isobutyrenol. And again, this is a chart that comes directly from first aid because you just need to become extremely familiar with everything in it. Norepinephrine, as I said before, it's primarily known for its alpha effects over its beta effects. So as we can see, when it is given, we have increases in systolic and diastolic blood pressure. There is a decrease in the heart rate of reflex bradycardia. And even though we are having some beta-1 effect, which would increase the heart rate, the alpha-1 effect is the strongest and driving effect of the norepinephrine, so you will have a little bit of a reduction in the heart rate. And then obviously your peripheral resistance is going to shoot up because we're using our alpha-1, and your peripheral resistance is decreasing because alpha-1 is a vasoconstrictor. Contrasted that with epinephrine, which sort of equally affects alpha and beta. Now, as we can see, our blood pressure is increasing, and so is our mean arterial pressure. However, we do have some beta-2 causing vasodilation, so there is a little bit of a dip in the diastolic pressure. As I said before, with norepinephrine, instead we have beta-1, which is going to drive our heart rate, and so therefore we're going to have a little bit of an increase in our heart rate as opposed to norepinephrine, which would decrease your heart rate. And then finally, we're going to increase our peripheral resistance because, as I had mentioned before, there are beta-2 receptors on the vasculature as well, and that actually is a stronger effect in norepinephrine. So we have some reduction in our we have a decrease in our, well, I apologize, we have an increase in our peripheral resistance, which is noted as it going downwards. When I talked about peripheral resistance in alpha-1, this it rises, but as it's rising, that's because our peripheral resistance is getting smaller. I mixed those two up, I apologize. finally, for isoproterenol, even though it does mention that there is alpha effect, you want to think of isoproterenol as only beta 1 and beta 2, as I talked about before. Because there's so much beta 2 effect, you're having a lot more of a drop in your diastolic pressure, and you actually will have a little bit of a drop in your mean arterial pressure, even though your systolic pressure is going up. And that is because of the beta 2 effects. You're going to have a reflex tachycardia over here. Your heart rate is going to increase. And then finally, you have unopposed beta 2, so your peripheral resistance is going to just increase dramatically. You're going to have a lot of dilation.